Urgent care is a category of walk-in clinic focused on the delivery of ambulatory care in a dedicated medical facility outside of a traditional emergency room. Urgent care centers primarily treat injuries or illnesses requiring immediate care, but not serious enough to require an ER visit. Urgent care centers are distinguished from similar ambulatory health care centers such as emergency departments and convenient care clinics by their scope of conditions treated and available facilities on site. While urgent care centers are usually not open 24 hours a day, 70% of centers in the United States open by 8 a.m. or earlier and 95% close after 7 p.m. Urgent care outside of the USA. Although the urgent care movement began in the U.S., urgent care centers are now an important healthcare delivery component in several other countries, including Canada, England, Ireland, Australia, New Zealand and Israel. Urgent care in New Zealand. The Royal New Zealand College of Urgent Care runs a 4-year fellowship training program in urgent care. In 2000, New Zealand became the first country to recognize urgent care as a medical specialty. AMCNZ report estimated that urgent care clinics then accounted for 9% of consultations in primary care. In 2007, a New Zealand medical journal paper defined these clinics by on-site X-ray facilities, opening hours, and being community rather than hospital-based. Typically limited liability companies with salaried staff in a central city location, they were distinct from both the deputizing services available to general practitioners in the UK, and the cooperative after-hours centres becoming more common in the rest of the Western world. This paper summarised findings from a 2001 MOH report in which data was collected from 12 randomly selected clinics. Injury, poisoning, respiratory and non-specific symptoms were common presentations. Consultations took, on average, just over 15 minutes, with most relating to new or short-term problems. Depending on the time of day, X-rays were ordered on between 1/5 and 1/6 of visits. Overall, about half of visits resulted in a prescription, commonly for antibiotics or analgesics. About a quarter of visits during normal hours resulted in no treatment. During normal hours, 4.2% of patients were referred to a hospital emergency department. Like general practitioners, but unlike hospital emergency departments which are free at the point of service, NZ urgent care clinics bill patients with a par charge, as 1/3 of consultations were subsidized by ACC. In March 2008, the Accident and Medical Practitioners Association and the Australasian Society for Emergency Medicine hosted the first International Urgent Care Conference in Auckland, New Zealand. Subsequent annual conferences have been held in partnership with the Goodfellow Symposium. History of urgent care in the United States. The initial urgent care centers opened in the 1970s. Since then, this healthcare industry sector rapidly expanded to approximately 10,000 centers. Many centers were started by emergency medicine physicians, responding to a public need for convenient access to unscheduled medical care. A significant factor for the increase of these centers is significant monetary savings when compared to ERs. Many managed care organizations now encourage customers to utilize urgent care options. 3.1% of family physicians in the United States now work primarily in urgent care. The male-female ratio of this workforce is 6:7, and the urban-rural ratio is 2:1. This compares to 3.6% of family physicians working primarily in emergency care, with a male-female ratio of 5:3 and urban-rural ratio approaching 1:2. Criteria for urgent care centers. Both the Urgent Care Association of America and the American Academy of Urgent Care Medicine have established criteria for urgent care centers and the physicians that operate them. Each share similar qualifying criteria including, must accept walk-in patients during business hours, treat a broad spectrum of illnesses and injuries, as well as perform minor medical procedures, have a licensed physician operating as the medical director, be open 7 days a week, have on-site diagnostic equipment, including phlebotomy and X-ray, contain multiple exam rooms, various ethical and business standards. The UCAOA program is called Urgent Care Certification and the AAUCM is called Urgent Care Center Accreditation. Organized medicine and urgent care. The Urgent Care Association of America holds an annual spring convention and an annual fall conference. Many leaders of organized urgent care anticipate the establishment of urgent care as a fully recognized specialty. Urgent Care Management Monthly hosts a biannual conference, teaching doctors, investors, and owners about the business side of an urgent care center. Urgent Care Management Monthly is the official publication for urgent care management, with discussions on topics such as billing, staffing, marketing, accounting, and logistics. JUCM, the Journal of Urgent Care Medicine, is the official publication of the Urgent Care Association of America. Each issue contains peer-reviewed clinical and practice management articles. Board of Certification in Urgent Care Medicine provides board certification for physicians with requisite training and experience. Urgent Care College of Physicians. Postgraduate training. In 2006, the Urgent Care Association of America sponsored the first fellowship training program in urgent care medicine. A collaboration between the Department of Family Medicine, University Hospitals of Cleveland/Case School of Medicine, the Urgent Care Association of America, and University Primary and Specialty Care Practices, Incorporated in Cleveland, Ohio made this fellowship possible. The program was partially funded by an unrestricted grant from the Urgent Care Association of America. Fellowship physicians receive training in many disciplines, including adult emergencies, pediatric emergencies, wound and injury evaluation and treatment, occupational medicine, urgent care procedures, and care center business aspects. In 2007, the Urgent Care Association of America sponsored a second fellowship opportunity through the University of Illinois. The one-year fellowships are opening to graduates of accredited family medicine and med-PEDS residencies. Staffing and services. Unlike other walk-in clinics such as retail clinics, urgent care centers are generally staffed by a physician and supported by nurses, physician assistants and medical assistants. 65% of urgent care centers have at least one physician on site at all times. Of the physicians that staff urgent care centers, 47.8% are family medicine, 30.1% are emergency medicine and 7.6% are internal medicine. With these licensed physicians on site, urgent care centers are able to offer a wide range of services including broken bones, moderate cuts and lacerations requiring stitches, and most common injuries and illnesses. These services, of course, are made possible with the diagnostic equipment and X-ray machines typically found at an urgent care. Of course, the urgent care centers are not an emergency room and do not offer surgical services. That said, an estimated 13.7 to 27.1% of all emergency department visits could take place at an urgent care center or a retail clinic, generating a potential cost savings of approximately $4.4 billion annually, according to a 2010 study in Health Affairs. Hours of operation. Urgent care centers are usually great options for seeing a physician, particularly after traditional office hours, on weekends or even holidays. In fact, 85% of urgent care centers are open 7 days a week. Common hours of operation are 8 a.m. to 8 p.m. daily. In fact, 81.1% of urgent care centers are open by 8 a.m. and 90.6% are open until at least 7 p.m. These extended hours are particularly helpful if patients are looking to avoid the hassle of hospital emergency rooms for less severe conditions. Over 80% of ER visits occurred during the most common hours of urgent care centers. Ownership. The majority of urgent care centers are owned by physicians or physician groups. However, more corporations and investment banks are acquiring urgent care centers and creating regional and national brands in the industry. The following is a breakdown of urgent care ownership following a 2012 study by the UCAOA. 35.4% of centers owned by physicians or physician groups, down from 50% in 2010, 30.5% owned by a corporation, up from 13.5% in 2010, 25.2% owned by a hospital, 4.4% owned by a non-physician individual, 2.2% owned by a franchise. Urgent care centers by state. given the constantly evolving industry and opens and closures of urgent care centers each week and lack of standardized SIC or NAICS codes it is impossible to know the exact number in the country, much less by state. However, according to the most accurate, known database of walk-in clinics, the following is a state-by-state breakdown of urgent care centers. Point-of-care medication dispensing. Point-of-care dispensing enables healthcare practitioners in the urgent care setting to ensure that their patients receive their prescription prior to leaving the clinic. To offer this service to patients, urgent care centers generally contract with a point-of-care dispensing corporation. Point-of-care dispensing enables physicians to dispense at urgent care facilities. Unlike a pharmacy, practitioners may only dispense to their own patients. Regulations regarding state pharmacy law vary from state to state. Dispensing by a healthcare practitioner is not legal or quite limited in certain states, such as Texas and New York. Group purchasing organization. Group purchasing organizations, focusing on the urgent care industry, have been formed. The concept of these GPOs is that they join hundreds of urgent care centers together to allow the type of price bargaining that previously was only available to hospitals. Medical malpractice insurance. Malpractice insurance offerings unique to the urgent care industry have begun to be widely discussed in light of the fact that many insurers do not recognize the reduced malpractice risk of urgent care centers. Insurers that recognize this reduced risk do not group urgent care centers with hospital emergency physicians and other high-risk specialties. Features of this type of insurance may include no charge for tail coverage when providers leave, 3 to 5 day approval of new providers, no additional premium when providers are added to the policy, per visit FTE rating, and lower premiums. Codes for urgent care. In recent years the American Medical Association approved the code UCM. This code allows physicians to self-designate as specializing in urgent care medicine. Services rendered in an urgent care center may be designated, using the place of service code -20 on the CMS 1500 form, as submitted to third-party payers. The Centers for Medicare and Medicaid Services have designated two specific codes to apply to urgent care centers, S9083 and S9088. Advantages of urgent care over emergency departments. For injuries and illnesses that are urgent but not life-threatening, it is more efficient to use urgent care than an emergency department in terms of both money and time. The typical wait time to be seen at an urgent care center is less than 30 minutes, compared with hours at an emergency department. As of 2009, urgent care centers cost less than emergency departments and have the potential to provide much more efficient care for non-urgent cases. Reimbursement by insurance companies for urgent care centers is comparable to general family practice reimbursement, which is well below the average contribution for emergency department visits. References. External links: Urgent Care Association of America, American Academy of Urgent Care Medicine, Journal of Urgent Care Medicine.